everybody. So today we have Dr. Moon. He's one of our preeminent transplant surgeons. He's going to be talking to us about liver allocation and donor selection, one of the most important pieces that I think sometimes we don't see as the hepatologists are deciding which donor to use for which patient. And Dr. Moon's going to talk to us about, the matchmaking involved and all that stuff. Dr. Moon,
okay,
thank you.
So this lecture, first of all, it's a recording, so I need to be careful of my vocabulary, which makes it almost impossible to deliver a lecture, but I will try.
We can edit it out afterwards in post-production.
Please.
Yeah.
So the main target of this lecture is hepatology fellow. So want to do this, fill the gap between surgeon and hepatologist. I just assume every hepatology fellow eventually in a few years you will take the lead on certain transplant centers hepatologists. That's how I expect it, that's how I imagine. Based upon different program, the job description is very much different. I think my previous career and current career is complete two opposite extreme. Let's start with a good thing first here, Mount Sinai. I've never seen hepatologists working this hard and supporting the transplant program. I really appreciate it. On the contrary, I came from, there was a zero hepatology backup, which was, I shouldn't say was University of Miami. I did everything, large volume paracentesis, liver biopsy, central line, endoscopy, and pre and post admission when a liver failure patient comes in, even as a surgeon coming 2 a.m., 3 a.m., quick evaluation, listening up. All of those now you guys are doing, right? So it is two opposite, I think, extreme example. So probably your future career will be in between somewhere else. So here, because you are working so hard, organ acceptance, organ surgery, recipient surgery, those kind of thing has a little weak point. That's how I understood. So I really try to fill up the gap. This lecture is not like a professorial according to the literature, 30%, 20% molecular level. This is not all of them. So it will be very practical and casual. I have emergency surgery, so I need to answer this. So speaking of casual, please stop me at any time. I really want to have an interactive lecture series. So first of all, because we all transplant physician, surgeon and physician, we want to use a proper language. This one is directly from UNO's glossary book. So quickly, we have two types of donor, living donor, and then deceased donor, right? Among deceased donor, there is a brain death donor and then cardiac death donor. So we call DBD and DCD, right? That's our backbone. Some of the language as you see here, a lot of people starting with organ procurement, organ retrieval, even organ harvest. All of them, what we can doesn't recommend to use this. When you speak English, I'm a second language people, so I don't know what kind of nuance in it. And maybe this one is a better, neutral vocabulary, but that's their recommendation. So please don't say particularly organ harvest. That even me as an immigrant, I can tell what harvest means. So we're using organ recovery. Another thing. Don't use any more cadaveric donor. This one is like 40, 50 years old terminology. This makes some of the fellow we go to the morgue and get the organ out. Really. I faced a few fellows saying that they understood I'm going into the morgue, dead body. So we're calling it deceased donor. And then we're not calling any more non-beating donor. Other than that, we use DCD. That means death after, donation after circulatory death or cardiac death. Okay? And then another one is a life support. Because from time to time we're saying that we withdrew life support and then harvest liver, that means it looks like I kill this one and then I crop like harvest the liver. So we're not using life support anymore. I think it is very important, particularly this, because it can give general population misconception. You know, if you do 999,999 good thing, and then if there's a one bad thing happen, all of those hard work before, it's drained into garbage. If it comes onto New York Times, done deal. It's going to correct. We need to correct spend many years to correct that misconception. So this one is a very sensitive touch issue: life support versus mechanical support. Right? So please use mechanical support in the donor lab. This one, please write it down. I probably most of them know all of them, but there are two very useful websites. This is all like a public record. Everybody can go in, can see without signing in, except you, man. Yeah. So you can get lots of data, situation of the other centers, and on and on and on. Please visit 1 or 2 times, saving one weekend 2 to 3 hours, and just navigate and find out what's in there. And you can even ask mass data from the national level, and you can even create meta-analysis and have a very good publication too. So this is a very good resources that you should know. So now start. Okay. Organ recovery and transplant surgery. If I see the viewpoint from the organ opioid point of view, this is monopoly. It is like Italian mafia to each geographic, and they do not cross the line. That is exactly what it is. So entire U.S. country right now divided into 11 different regions. So we call this is nation, everything nation, and then next segment is not state for us. It is region. Okay. So we are here, region 9, pretty homogeneous region because it's entire New York State and a part of West Vermont. Don't ask me why this geographical region divided like this. It's not coming from Abraham Lincoln or our founding fathers. But I know that this one is under some certain historical background, some dirty politics, whatever it is. So this is our state. We have 11 states, and we belong to Region 9. The famous, the most ideal region, Region 3, 1, 2, 3, 4, 5, 6, Southeast state. That is the transplant heaven. The difference between Madiscore, us, and them is humongous. I just talked to them 2 days ago. They're still capable to do the liver transplant Madiscore 25. For us, Madiscore 25, we don't even follow the clinic because they're far away. Some certain exaggerated version. But if they see biological Madiscore 35, 37, even 40, the surgeons are all scared off because of this Madiscore difference. Okay? But our average Madiscore, I believe, is in the mid-30s. That's how I see it. So this, each region, transplant state, each region, divided into smaller segments. We call it donor service area or opioid area. They were compatible with county, right? Nation, state, county. Here, nation, region, and opioid DSA. So each region, entire United States, divided into these small numbers. This is all reflection of each separate opioid. 59 opioids from here to there. All of those opioids occupy some certain region, and then they don't cross the line. And, they should not allow to cross the line. They have their own territory. It's like mafia. It's like I said. Here in New York, this entire region 9, New York State, is divided into 4 different opioid territories: NYRT, NYAP, NYFL, NYW. I think everything starts NY belongs to New York. example, if there is a California, it's going to be CA, blah, blah, blah. Okay? So there is a one designate first two letters, and then this is a specific name, so-called last name and the first name. So this one here, region 9, is here, divided into different ways. Right? So by the textbook, let's start from the small thing. Transplant surgical center belongs to certain local OPO, right? Then that goes out region, and that goes out national, right? I'm repeating again, national, regional, and local. In that sense, we belong to here, NYRT. So the rest of the centers, locals, for us, has to be not local, has to be regional. Isn't it? We belong to NYRT territory, and then even though it starts with the NY, APFLWN is covering the rest of the New York State. So by the concept, it has to be regional. And then if it outbound, that is all national for us, for our point of view. Now, there is a very special thing in the New York. There is a New York State Liver Transplant Center Consortium. The problem with New York is we have 7 liver transplant centers in entire Region 9. Among them, 6 are located nearby Manhattan. So 6 are belong to here. And the only one, Rochester, which is, I believe, here, right? Yeah, I think so. So, because of this geographical or transplant business specialty, so in the New York, Region 9, we don't have a region. So anything starts with NY, we call it local, based upon those 6 centers agreement. So for our point of view, there is no regional. Everything is local. And then we jump up to national. That is very important because that means we are willing to share or organ the rest of the region 9. If we follow the dictionary, this is only local, and this is the only main source of our organ, then we have 6 centers belongs to here, then it's going to be like hell. So that's why we opened up this as a local. So remember, national, regional, local. But here, this is the only state and then region that we share local and regional at the same level. The organ offering process. So now, just a quick Region 9 profile. Geographically, as I said, New York and then Western Vermont. There are 4 OPOs. Transplant always happening along with the grid. And then there are 16 transplant centers, but liver transplant point of view, 7 centers. 6 centers nearby our 20 mile, 30 mile radius, and only one is all the way up to Northern New York State. I just quickly researched this number from the previous website, OPTN. It is always updated. So I found that liver transplant 2018, New York State Region 9 made 480 deceased donors. So there were 480 deceased donors. And then among them, liver transplant happens 403. As of yesterday, on the liver transplant waiting list, 1,134 patients on the list. Doesn't matter high score, low score, anyways, or internal, like cold, whatever it is. There is more than 1,000 people is waiting. For your information, we're not the worst, thank God, in the whole of America. We're not the worst. Second worst. I want to be number 1. Then who's the number 1? California. Okay? So, in other words, you see anything in this area, and you survive this competitive and then bad system. The rest of the world is piece of cake for you, just except for one, California. California. So other than that, it's going to be piece of cake. That's good aspect. Now, what is really happening about this organ donation, transplant, and OPO business? So there are three different levels: individual hospital, OPO, and transplant centers. So it all started with the individual hospital. If they have like a questionable, possible brain death patient, by the Medicaid and Medicare rule and law, they should, it is mandated, they should report possible brain death to the local OPO. They should. Why I keep saying should? Because it is not always like that. But anyways, they report to OPO, then OPO dispatch on-site donor coordinator, and then quickly do a brain death diagnosis. Once brain death diagnosis is made, from that moment, there is a paper, brain death. When I go to the donor surgery, there's lots of papers, of course. One of the most important thing is confirmation of brain death. Depends on the state and the local hospital. There's something different here and there. For example, some state mandate brain flow test. Some state they have to flat EEG, something like that. Some state has no. You just need two physicians confirmation, post confirmation through apnea test only. So whatever, there is a separate protocol, and then if they made the diagnosis of brain death, it's going to come out like this: September 29, 2019, 6 p.m. There are two physicians confirmed brain death. From that moment, that patient is not patient anymore. That is dead body. From that moment, even though life support, no, through the mechanical support, patient get oxygenated, heart is still beating, and the organ is circulating. So even though it looks like this is deep comatose patient, but once they made the diagnosis of brain death, from that moment, it doesn't belong to one of us. It belongs to the next level of the world. Then that moment, OPO takes over the management of the donor. So from that moment, the hospital attending physician, whether it is they sign up, because this is dead body. Of course, during those management, OPO will ask, in our work, we'll make a consultation to local physician at that hospital, and then ask them to do this and to do that. Still, there is a medical practice involved, right? They're using some resources, occupying bed, or using CT scan, or do the liver biopsy. All of them created expense. That one is under transplant, the expense belong to them. Okay? So another important thing that people should do is consent and the family care. So this is a huge. So the OPO point of view, they even have their own analysis dashboard, such as conversion rate. So once you have a brain death, then OPO should approach family, get organ donation consent. So let's say there is 100 brain death, consent could be ideal world, I don't have 100, but it's like a 90, 85, or some bad area going down to 70. So that is a conversion rate. OPO wants to increase as high as possible, as if we want to protect the clinical outcome presented by the one-year patient survival. Right? It's exactly the same thing. It is very important dashboard for OPO. And then the organ allocation system initiated. Then we get the UNOS notification. And then we go down and then start to try to find out, okay, this donor is good donor, bad donor, and then this donor fit for patient A or C, something like that. Which, and then, of course, prepare the recipient, hold them in, make a donor team, hold their charter, on their phone call, and then make ready to dispatch our donor surgery team, and then make our donor ready. This is what we're going to do. Here, among those fellows, anybody saw UNET record? Anybody? Good, right? So then, where did that go? Okay, this is UNOS UNET. Okay, one looks like this. So if I enter, there are 4 different areas. So you can see the waiting list, you can see donor, you can see the after report, whatever. So now I'm going to UNET. It looks like this. So this is the past 3 days, the organ offer that we have. Opio name, as I said, GA means, I think it's Georgia, right? Arizona, New York, Pennsylvania, something like that. You can tell by the last name. And then each opio has a first name, 2 letters. This is UNOS ID. Another secret, if you're familiar with the UNOS ID, you can exactly tell time. This one is a code, but this represents 2019, October 3rd, nationwide 3rd donor, something like that. That is created automatically based upon when it's happening. And then there's organ, pancreas, liver, kidney, pancreas, liver. There's sometimes intestine, KP organ offer. This is each identifier. Each organ allocation has a different ID number. And then we have some certain limitation to respond to this organ offer. I believe this is 1 hour. If my coordinator sleep, or if I fall asleep and then not giving the final answer yes or no, then we'll be kicked out from this market. Okay, there's a limitation of time. So let's pick one of them. Let's say Arizona. So if you go for this, there is a donor information and a match result. Let's start with the donor result. So I'm sorry, donor summary. So there is a opio, hospital, which time zone, basic demographics, age, height and weight, and then description of cause of death based upon their classification. And then if this organ recovery happened, even though we don't want to use the procurement, but they're still using it. So opio itself is an organ procuring organization, even though they recommend to use the recovery. So we are mixed, but let's use the recovery as a procurement. And then even they give the cross-claim time, and then there is some highlight. If it is a DCD, yes or no. If it is a cardiac arrest downtime, yes or no. CPR is yes or no, and then donor highlights. If you read this, it's going to give you some idea how this patient passed. My personal complaint of those 2 sections are, it is totally dependent on local on-site coordinator. So some of them wrote it down as a gibberish. I have no idea what they mean. Lots of abbreviation, which is not commonly used, and they missed a very important topic too. But what can I say? This is like a personal difference. But those 2 things, donor highlights and admission course, will give general idea what kind of donor it is related is that. And then there is some medical social history. Again, coming up, medical social history coming too. And now it's all the lab. ABG, CBC, ASD, ALT later on. This is CBC, BMP, CMP. So I can tell current lab, including urinalysis, and then ABG, and then ventilator setting, and then toxicology result, and then also there is a culture report, and then current medication, including hormonal cocktail or vasopressor. Important thing here is serology, B-Core, Hep C, HIV, EBV, CMV, and then some of the lab tests they do. Sometimes using this amazing technology, we can even see actual image and then biopsy slide through this system, and the HLA, and then the rest of the information. This is about the donor. Then, if you go to match result, it's going to come out like this. So there is a classification. The pool of organ offer, like a national level, regional level, local level. That one I'm going to go later on, but there are some tiers, and then it starts showing up our patient. So on this particular organ offer, we started with the sequence 50. So that means about 1 to 45 some other centers, and then now we are showing up of the 50s. If you want to see other centers situation, then you can put view candidate from all centers. Then suddenly it shows lots of this asterisk mark, which is from other centers. Each sequence, age, ABO blood type, height and weight, which organ they need. This patient obviously needs liver and kidney. This one needs liver, kidney, heart. And then when you see on the side, there is a provisional yes or decline X. So on this particular organ offer, now our patient is 50. This is our first patient. Even though I put provisional yes, there are this many provisional yes. So if I see this one is, you can just see provisional yes only, exclude all the listing patient. Then I can tell, I need to go down further. Even though I put provisional yes, our patient is sequence 38, means 37 ahead of us. Even though this is a DCB, it doesn't look like this organ is going to come to us, right? This is kind of our business during the nighttime, what you're doing. So UNET, if you have this one requires user ID and password, and you need to register. But if you see this, you're going to learn a lot about the donor and the recipient. And actually, this is interesting too. Like if you have insomnia, like 1 a.m., 2 a.m., open up UNET and then looking at it. It's fun. What you're going to do, it's really fun. Okay? Sometimes the worst case scenario among New York, there is some questionable 83 years old donor, have history of this and that. It's not really like everybody jumping on. Then if you see about 6 other centers, including us 7, right? There will be patient, center A, center B, center C. It's like an evenly distributed. They're going to lift off one by one. Initially, yes. 10 minutes later, lift off. Next one, looks like they're going to upset. Another 10 minutes later, they lift off. It's going to come close to us. For example, we are very, I think you should be very proud. In the New York State, we are the biggest and the most busy and the most aggressive, and yet still have a very good outcome, liver transplant centers. So for example, like a DC, they have C donor, nobody, the rest of 6 centers suddenly became very conservative, but they don't set back everything. Sometimes they just lift one by one. So even though our sequence is like a 20, open it up and looking at it, it's coming 19, 18, 17, 16, and then finally we become primary. In ideal world, if they don't want to use it, they need to just say no everybody and then out. And then we can be as a one step as a primary, right? But in real world, somehow, I'm not saying that every case, somehow it happens like that. Okay, so that's UNET that I want to show it to you. So this is really what's happening during the night time between Opio, us, me, and then coordinator. So liver allocation is, in a very simple way, it is happening on the donor net by value score. Done. You got it all, go home. So this is really key to learn.
What if 2 centers have the same exact top value score?
If it's the same, then time matters. Whoever listed earlier goes above. It's like there will be no same sequence at all. It will be always organ, always. It's like a World Cup or whatever, the American League, even though they have the same winning rate, the winner was the winner, and then whatever. There's always like a ranking system. Okay, so now need to memorize, but you need to have at least one concept. Organ offer happening always local first. And then once they exhausted local organ offer candidate waiting list, they move on to the regional. And then after regional, they go to the national, right? That is the bottom line. It has been like this ever since this system launched, with some certain period of different tweaks and different exception rules. Most recently, the most prominent one is the med score tiers. So, as I said, it has to be started with the local, but however, what if there is a status 1A in adult? So, depends on how sick patient is, also depends on the med score. The way they're running down the list is this order. Status 1A, 1B, local and regional. And then after that, med 40 local, med 40 regional, 39 local, 39 regional. You follow me? So, the sicker patient, they're given some different tiers. And then suddenly going down, med score above 15, local, regional. And then stages 1A, 1B, and this one showing up at the national level. Because even though I have a status A, I'm not going to accept organ from Hawaii, right? Because it's too far, because it's too long. So in that sense, national coming up like this, and then look at this national, local, regional, national. Get it? This is how we do it. So here, if the donor is 18 years old or less, the pediatric candidate gets the priority because size matters. So we cannot use like a Shaquille O'Neal's liver into 2-year-old baby, even though we chop it down. Mechanism doesn't fit. So size matters because of that size. If donor is 18 or less, there's always pediatric gets the priority candidate. And then waiting time breaks time. Your question. When med score is the same. So waiting time the longer, and it goes up. Another caveat here is, from time to time, we see patients much sicker than their med score, right? You saw a lot of people at the clinic. They need to be recognized on a special pathway. So there's a regional board, and then we claim, file, hey guys, this is the situation, this and that, and then even though his med score is 22, considering urgency of the transplant, can you give us 31 or 32? And then they all vote. And if they agree, then that patient has listing med score. So there are 3 different med scores. Biological med score, exceptional med score, and then also recently we added sodium med score, right? So there are 3 different med scores. What matters is listing med score, because organ offer coming along with the list. So this one I showed to you. Remember https://forum.unos.org. Okay, so let's do this. Donor. This one is unpublished data using 1999, 2001. It's almost like when you guys are in the kindergarten or not even born. But so their concept is, what is optimal donor? What is a good donor? That time, what they wrote it down is between 10 and 45 years old, completely normal liver function, and unremarkable medical history, and brain death less than 5 days. With this, good luck trying to find this donor. This donor may be 1 or 2 in a year, right? So for example, 25 years old guy, gunshot head, no DM, no hypertension, social drink, no smoke, ACLT better than mine, everything stable. If you think this is an optimal donor, and this is the first class donor, this is the donor that you want, that means at the same time, I don't want to do liver transplant. That's what it means, right? So our real world, this is our real world. 65 years old, died of a stroke, which means there is a vascular disease. Big guy, BMI 32, diabetes under insulin, hypertension with medication. 3 bottles of beer every day, is ALT peak 500, and now it's not even normal. Creatinine is high, 2 pressors. This is good donor. This is good donor. So using this one, optimal donor, what is good donor? Doesn't exist. Doesn't exist. So now, the organs in the imperfect world, yes. Everybody has underlying medical problem, and then there's a growing obese population, and then organ is always shorter than the supply-demand discrepancy, and then we're doing some expanded criteria donor. Expanded criteria donor means not usual donor, which increase the risk. And then during the organ recovery, there's an injured organ, and then all the donor surgery happened in the middle of nowhere. They don't know me, and then they don't know how to do the surgery. It's all based upon some of the hospitals are really small community hospitals. So we need to go there and we need to recover the organ from them. So it's all imperfect work. So now, it's kind of a joke, but let's read it. So I just came home after 16 hours of a long and very difficult transplant. I'm tired. I'm really, really tired. And I want to have some rest. Suddenly, 5 minutes after, there's organ offer. 65 years old, BMI like this, not perfect organ. Bedside liver biopsy, 25% of macrosteatosis. And by the way, because this is the last transplant, I missed important family occasions. So my wife is upset, and now because of that big fight, now I'm upset too. Now I'm tired and then angry. And then my recipient looking at it, I have a liver surgery, 3 coronary stent. Oh my God, this is going to be a difficult case. My inner evil. Decline. You take a rest. Don't you think so? It's not. It's a perfectly not good. Donor has a problem, lots of problem. Recipient has lots of problem. Surgeon has lots of problem. Is it going to happen? Really? Unfortunately, this is daily life. So before I make a decision, I need to think about this. All right. So all we want to do is, after we do liver transplant, I want to have nice outcome. Here, nice outcome means patient goes home, achieve transplant purpose. What is the purpose of the liver transplant? Which is end-stage liver-related all kind of complication gone, and then get reasonable expected lifespan. Right? That is our goal. That is our goal. To make it happen, there are so many studies for the past 40 years. There is a risk factors to compromise the result that we want. So from this moment, let's be logical. So let's dive in. Okay, so there are 3 groups of the risk factors. Number 1 is recipient-related risk factor. Number 2, donor-related risk factor. And then surgical risk factor. Among them, importantly, some of the risk factor I need to suck it up. It is what it is. Some of them I can make it better. So-called, there is a controllable, avoidable risk factor versus there is uncontrollable and given risk factors. So in idea 1, what I need to do is using those risk factors among the patient and recipient, and then regarding our team's situation, it has to make reasonable risk. There is a zero risk liver transplant. There is no zero risk liver transplantations. Just want to have a risk factor as low as possible, which will statistically guarantee good outcome. Make sense? So this is all about risk management, risk factor management strategy. Either which organ I accept or which organ I'm not going to accept. Okay, so here, I really think it's ERMlimits.com. Whenever organ offer comes in, I show you UNET. There is a patient list coming out with a certain one donor, right? So don't think about other centers, among us. Number one patient, considering this patient's risk factor and the donor risk factor, you know what? I don't think it's going to work. Then I need to decline that particular recipient candidate. And it's going to go down one by one by one by one. This is really stuff. Right? And finally, we commit. If this organ comes to us, I'm going to use this organ to this particular person. Okay? Not like pulling out 2 to 3 candidates and then I'm going to juggle around it. No, it doesn't work like that. One patient, specific patient. Having said that, I want to you saw our usual donor. So change your brain. There is no such a thing, first class liver, second class liver, third class liver. No, there is no such a thing. Believe me, there's no grade. We only have good liver or bad liver. And we don't use bad liver, we only use good liver. When I say good, that is after I did match business. So even though how scary this donor and liver looks, if there is good match with a certain patient, that liver is good liver. So when you explain to the patient in the clinic or in the hospital, don't say that, don't give any nuance or impression that there is a grade of the liver quality, first class, second class, third class. No, good liver. So you explain, we only use good liver. So that is the right thing to do. There is a lot of study like this. I'm not going to go one by one. All the publication, which try to identify risk factors around the liver transplant. Just to read it, it's good to know, get some concept. But all of those are not like the words from God mouse and then written in the cart in the sun or the sun. Now, this one I need to think about this. To be honest, I don't know. So this is the example. Patient is very sick. Biological mental score like 47, ICU, like a very debilitated, sick patient. A lot of ascites, deep encephalopathy. I think there are 2 strategies to match this organ. Because this patient looks like he's going to die, so whenever organ available next, I'm going to give it to him. Or versus, no. If we do that, this would be futile transplant, which means after transplant, patient is not going to make it. So because he's very sick, I need different type of donor using prior concept, good first class donor, such as 25 years old, complete stable, liver function test, blah, blah, blah. So there are 2 different strategies. I think each strategy makes sense because high MELD score means there's very less expected lifetime without liver transplant. So liver transplant needs to be done super urgent. So whenever organ is available, we need to use it. And cross my finger, pray God, Hail Mary, and then see that this patient survives or not. That makes sense. At the same time, to avoid futile transplant, because recipient has so much risk factors, I need 0 risk factor donor. Makes sense too. My personal position, I don't know. But my personality, if I need to be forced to pick, I'd rather pick later scenario. The low risk donor to high risk recipient. Because for me, it's a matched outcome. So risk factor molding. So if recipient has this much risk factor, donor has so small risk factors. That depends on my personality. Again, I don't know. Again, I don't know. But I think, at least the center point of program point of view, we need to be consistent. Okay? If we play every time differently, we don't learn anything. So, ideal world, this is what it has to be done. If the sick patient, whatever first liver comes in, we'll do it, and do it 1, 2, 3, 4, 5 years, and then go back retrospective analysis. Okay, this works or it doesn't work. We need to have some academic stuff. If you read all the journals, still those 2 things are coming out, and then every time it's different. That is totally center-oriented thing. So you can get an idea, but I strongly recommend not to follow exactly what they say. So I don't know. I really don't.
Is there any role for discussing with the family and
Ah,
because you do share with the family, right? This
Okay.
type of organ.
okay, especially in New York State in the 21st century, in the United States, legal law this and that, it is mandated to disclose clinical outcome and to disclose. There's a step that coordinator called 2 a.m. to the family. I have organ offer, blah, 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 blah. That is in our terminology. We are offering organ to the patient. And then only do when they say, yes, I will accept it, right?
So how much do you share?
Or it is mandated. What do you think? I think this is, I need to use some word.
Sure, yeah. Earmuffs.
This is really big, I think. Okay. Now I'm giving calling to, with all due respect, the patient, the family, they are high school graduate, and then entire their life is farming. And now we're talking about DCD, AST, ALT, CDC, high risk, this and that. Do you really think they know what it means? It is on us. I'm not going to just accept every organ. I already exercise all of those risk benefit factors, and then I think it is reasonable. That's why they came to us to see. This one is our obligation to serve the patient, have a good decision process. But unfortunately, this legality and this and that, yes, we need to present to them. As if like they make their own decision. And that means for me, something bad happened, you know what? You picked it, it's not my problem. I think it's almost I feel like this is a defensive medical practice example. I think, personal opinion. So this one, for the time, I'm not going to do it. Okay, so now, the problem here is, just to read it quickly. So now, let's think about this. You want to buy a can of soup in the grocery. Think about that one, okay? What's happening is you go to AMP, Publix, wherever, you go the soup section, and there are hundreds of soup in front of you on the shelf, right? Then you can pick the best for you based upon the brand name or taste and price. So you can get the best soup that you want out of hundreds. I wish that's transplant business, but the transplant business is very much different. You are on the line of the grocery store. In that line, there is hundreds and thousands of the line. And then they only allow one person goes into the grocery shop. And then when you go to the soup section, there's only one can is available. Specific brand, taste, price, whatever it is. And then the owner asks you either take it or leave. That's organ offer. So, okay, unless I have life-threatening allergy on this soup can, I have to think about, okay, I'm gonna buy this and then have it, or let's go all the way back to the line and looking for another can. Hopefully, that another can, I enter the grocery shop sooner than later. Hopefully next time it's a better soup. That's what it is. Because organ offer, it's only happening one by one by one. There's no organ offer having 5 in front of you and you pick. There's no such a thing. So when you pass that soup, you have to have strong rational and scientific evidence that why you need to decline this. Because you never know when it's going to be your next time. And also, even though next time is 2 hours later, there's no guarantee that better merchandise is going to show up. Maybe next time is even worse. So that is how we need to make a decision during the night time. All the problem is this. demand, supply difference. It's all the problem. One we really need to avoid is a futile transplant. Futile transplant is when you do the transplant, you know that this patient is not. And that one, it is not allowed on this time. It used to allow 20, 30 years ago. And then they're saying that heroic movement, life-saving procedure. You know what? Among those one survivor, actually, at the bottom of the sea, there are 99 miserable mortality. They only put it out, publicate, or whatever it is, only one successful case. You need to see the entire picture of it. So, who needs liver first? Many factors, urgency, and then at the same time, I want to avoid futile transplant. And also, we don't want to discard any organ. So this organ needs to be used. So it has to be very simple and objective. Even though I say a lot, like 40 minutes like this, even though I thought about this organ offer 1 day or 2 days or even a week, at a certain moment when I need to make a decision, I need to make a decision. That decision is very simple, either yes or no. There is no such a thing, I'm a little bit pregnant. Either I'm pregnant or I'm not pregnant, right? So at the end, that's why surgeons, we only have 2 brain cells. Yes cell, no cell. We're very simple animal. Either I cut or I don't cut. At the end of the day, that's our job description. Either yes or no. So everybody should have some simple logic how to make this, considering all of those I told you. And then it has to be verifiable. When the UNOS or JACO have audit, it has to be written and it has to make sense. Not cutting off one patient without any reason. It looked very suspicious if it happened. Okay, so MELD score system is launched early 2002. I still remember because that time I was fellow. It caused lots of problem, but a lot better than original UNOS criteria. Because UNOS criteria is only status 7, status 3, status 2A, 2B, and status 1. And always there's no objective. I mean, MELD score we cannot manipulate it, right? Because based upon the numbers. But UNOS classification, there's a lot of subjective things, such as presence of ascites or not. Of course, every my patient has ascites because I'm going to get higher priority, right? And of course, my patients are a lot sicker than your patient. So there was a lot of unintentional foul play there. So since the medals were launched, there will be no more those kind of stuff. Basically, this is formula how to create ranges 6 to 40 on the waiting list. So if you see medal score 5, that's something wrong. This is all like a risk-benefit analysis, a statistical game. They pulled out all the risk factors, do the massive analysis, union multivariate analysis, and then they found out meaningful relevant risk factors. They throw out on the chart and then see if there's a correlate between what? Mortality and numbers, right? So it's not from 0 to infinite. There is a certain window, which is MELD score 6 and 40. With that window, MELD score reflects mortality possibility without liver transplant. So if somebody says that my MELD score is 4, that means he does not know that what MELD score means. And then on the waiting list, there is no MELD score 42, 47, 57. Even the biological calculation came out 57. It is all capped at 40. Because after 40, it doesn't correlate that well because the dot is everywhere. Below 60, dot is everywhere. Between 60 and 40, there is a correlation, nice correlation. That's what it is. There are some adjustments like this, AGCC, regional appeal, etiology of the liver disease, some kind of thing, plus sodium level, this and that. So there is always exception. But as of now, MELD score system is not the perfect one, but as I witnessed, this is the best one so far. So I said not perfect, but the best by far. And the beauty of this country, the power of this country is constant discussion and constant revision of this MELD score. So it's detailing down and try to be as perfect as possible. But it's not going to be never ever perfect, but the best system. So just our common sense, that is for 40 or more, observational mortality within a certain period of time is 70%. So when med score comes down, the mortality probably is coming down. So now, because of this, using this, interesting thing is, at certain med score or below, there is a better possibility to live than get the transplant. See? At certain point, it's going to be reversed. At certain point, because your expectation of mortality is so high without liver transplant, even liver transplant risk, they're providing opportunistically better outcome. But when it comes down, it's going to be make a dead cross. Without transplant, provide a better possibility to survive at certain point. Which, if I'm not mistaken, that number is 15, biological medicine 15. I don't know yet that's true or not, but that was my understanding. Is it true? Yeah, he said it's true. The PEL score, completely different animal, the different formula, different age group, but again, the same concept is based upon PEL score. The organ, the acceptance priority is designated. I just want to go quickly the Child-Pugh score because this one you guys are still using it. I think this is very good scoring system. So I don't want to explain this to you guys, but all of this measure point, and then this is Child-Pugh score, and then which is class ABC, 1 year survival, 2 years survival. It's like this. This is correlated too. But however, we don't use Child-Pugh anymore because it contains some subjective issue like this and this. Because always my patient has moderate to severe ascites and fitness fight against other centers, right? So that is not a good system. So liver allocation in melt era. So anyways, it's based upon ABO, height, weight issue. Again, who said size doesn't matter? Size really matters. Size is everything. Everybody knows a small liver, they can go into small pore size syndrome. It's very well known. But you know what? Really, the much more dangerous thing is big liver doesn't fit into cavity. They will die on the operating table. So really size issue. So if you see the problem of this United States, because it is a melting pot, especially here, there are so many different races and ethnic background. The proportion is very different, from 6'5", 300-pounder to 5'2", and then 80 pounders. We have so much variable here. So really, I cannot use extremely big guy liver into very small patient. I said it is much more dangerous than small pore size. So again, when you see the patient at the clinic, if you recognize this patient's size is smaller than usual, then you need to mark it. You need to let the surgeon know. You got to be careful. If not, we may kill the patient. So what's the size? Size is here. All I mentioned is right upper rib cage size. Sandy and me has a big difference because we have a different race background. Usually Asian is very small, even though I put a lot of muscle in here, never been growing like that. But when you see Sandy different ethnic background, he was born with very nice cage. So he accepts a lot of volume of the liver. I can't. So you have to be sensitive on the size issue. I'm telling you, size matters. Size matters. Okay, so what time is it now?